Shall I start off straight away with I'll make a history examination of the hip joint. As Dr. Sunil has said initially, I mean, there is a lot of, I would say, a demographic variation among the examiners. For example, a south-based examiner and north-based examiner, there's considerable difference in their attitude towards an examination of the hip joint. But there are a lot of standard protocols which you need to follow. So history should be a relevant history. Okay, you don't need to tell everything in the history. It should be only a relevant history. And it should be in a chronological manner. For example, there was a 13-year-old boy who is presenting to you, and he had an injury at the age of 5 years. So you start off with, he had an injury at the age of 5 years, followed by he was admitted to the hospital, he was put on a traction, on a skeletal traction, or they did a reduction of the dislocation. He was immobilized for 6 weeks, and then he started mobilizing. At 3 months, he started walking, and then he didn't have any limp. At the age of 12, he started having pain and limp, and now he's 13. So that is the chronological manner which you need to describe when you take a history. So, and in general examination, all you need to do is a focused general examination. You don't need to say no pallor, no jaundice, no cyanosis, no clubbing, no lymph. All that is not necessary. If there is lymphadenopathy, say, okay, there is an inguinal lymphadenopathy on the right side. You don't need to say whether it is matted, rubbery in consistency, whether the vertical group or the horizontal group is involved. Not very important. That is more of a medical point of view. But of course, if you know, then you can say that. But you need to say that is a right side inguinal lymphadenopathy. There could be a chronic ulcer or an osteomyelitis on the same side. So focused general examination, and other systems you examine for the chest and the abdomen. If there's a hepatosplenomegaly, if there's a splenomegaly, could be an amyloidosis due to a chronic osteomyelitis, you need to mention that. Okay. So hip examination, inspection, palpation, movements, measurements, gait, opposite hip, ipsilateral knee, and other systems. That's it. Some examiners, for example, if you're in Delhi, they like to say gait initially. If, with due respect to Dr. Massey, he would like to say gait initially. But remember, gait is not very easy sometimes. It is tricky. So if you make a mistake in gait initially, then your remaining part is going to be a problematic. So if he is insistent, okay, say then gait, I would say, I've seen the gait and this is the gait. Otherwise, you go sequentially inspection. So instead of saying inspection, palpation, movements, measurements, look, feel, move, measure, gait. Opposite hip, ipsilateral knee, and other systems. That's it. So inspection, again, systematic. Front, side, behind. I've started 5 minutes early for this talk because Dr. Kulkarni has allowed me to speak for some time. Inspection, again, attitude and deformity. Whether there's an obvious deformity, whether the limb is placed in flexion, abduction, external rotation, or flexion, adduction, internal rotation. Look for wasting, look for bony prominences, look for soft tissue contours, any abnormal swellings, obvious limb length discrepancy. I'll show you an image after that, and skin over the joint. So, in detail, attitude and deformity. Look for flexion deformity. If there is exaggeration of a lumbar lordosis, you may need to come to the side and you look for the exaggeration of a lumbar lordosis. Remember that up to 30 degrees of flexion deformity will be compensated by a forward tilt of the pelvis. And only after 30 degrees it becomes really apparent, even without obliterating. Okay. So initial manifestation of up to 30 degree flexion deformity will be just an exaggeration of a lumbar lordosis. You may not see an obvious flexion deformity. Then you need to say whether there's an abduction or adduction deformity. I'll come to it. And whether it's an external rotation or internal rotation deformity. So attitude and deformity, number 1. Inspection from front. You look at the level of anterior superior iliac spine, higher level, lower level, or the same level. Okay, I'll come to it. Look for abnormal fullness in the Scarpa's triangle. There could be a cold abscess tracking towards the Scarpa's triangle. And from front again, you can look at the greater trochanter. Unless the patient is very obese, you cannot see the level of the greater trochanters, but otherwise you can still see the contour and the level of greater trochanter where it is migrated proximally compared to the opposite side. Okay. And again, look at the bulk of the thigh muscles, whether there is abnormal wasting. It's very obvious. Inspection, you can, in a chronic hip disease, you will definitely see abnormal thigh muscle wasting. And again, as I said, some swelling in the Scarpa, it could be a cold abscess. Look for scars and sinuses. Okay, this is all in inspection. Okay. And so going to our basics, in a fixed abduction deformity, the anterior superior iliac spine will be at a lower level. Okay, so initially when there's a fixed abduction deformity, The patient cannot walk like this, so what he'll do is bring the leg towards the floor, and there'll be a convexity of the lumbar spine to the right. So effectively the ASIS would be at the lower level. Okay, so that is very important. And the fixed adduction deformity. Example, this is the fixed adduction deformity. Now how the patient cannot walk like this. Okay, so what he'll do elevate the pelvis, so the ASIS is at a higher level, so he can walk like that. So you should remember that fixed abduction deformity, there will be, the ASIS will be at a lower level, there will be an apparent lengthening. And the fixed adduction deformity, the ASIS will be at a higher level, and there will be an apparent shortening. So another way to look, even on inspection, you can just look at the level of the heels. You can see that if there is shortening, it will be like this. So this is one way to look at apparent lengthening or shortening. This is all in inspection. Again, lateral, you look at the exaggeration of lumbar lordosis, look at the level of trochanter, whether there's any superior migration of the trochanter. For example, you can see in fracture neck of femur, DDH. In protrusio, the trochanter has gone inside, so the trochanter may not be very well palpable. Also, you should see that the patient is not very obese. In obese, you will not be able to palpate the trochanter very well. So in protrusio, the trochanter will not be well palpable. Okay. So again, scar sinuses or abnormal prominence on the lateral side. Posterior, as I said, in abduction deformity, there will be a compensatory lumbar scoliosis with a convexity to the involved side. Okay, if the left side is involved, I'm going to have a convexity to the involved side, and there will be lowering of ASIS. Whenever there is a lowering of the ASIS, even the PSIS is going to be lower. The posterior iliac spine is also going to be at a lower level. So look for symmetry of the gluteal folds. That will also come down when there is a abduction deformity, abduction deformity. Look for wasting of the gluteal muscles, scar sinus or abnormal masses. Okay, so this is from posterior. Palpation, always local rise of temperature, tenderness. Okay, fundamental things. Look for tenderness, bony thickening, swelling, soft tissue swellings, etc. So how do you look for the anterior joint line in the hip joint? Can someone say? Anterior joint line in the hip joint. What is the anterior joint line? You palpate the mid-inguinal point and then 2 centimeters below and lateral to the mid-inguinal point. So what is the mid-inguinal point? It is the distance between the halfway between the anterior superior iliac spine and the pubic symphysis, not the pubic tubercle. Okay, very important. So confirm the level of ASIS. How do you know what is the ASIS? How do you feel for the ASIS? You palpate along the inguinal ligament, upwards and laterally, and the first bony prominence that you feel is the anterior superior iliac spine. So look of ASIS may be less palpable if it is an operative case of DDH. The ASIS may not be well palpable. Okay. So again, look for front, Scarpa's triangle, look for fullness of any cold abscess. Vascular sign of Narath, very important. Feel for the femoral pulse. Okay. In the case of dislocation of the hip, old DDH, the pulse may not be palpable. It's not, maybe less palpable. It's not palpable, it may be less palpable compared to the opposite side, and then you say that the vascular sign of Narath is positive. Okay. So some examiners are, for example, I said there's a demographic variation among examiners themselves. So someone will ask you, why do you say the vascular sign of Narath is positive in a dislocation? So normal answer will be that you palpate the femoral artery over the femoral head, but some examiners don't agree. They say that you palpate the femoral artery over the iliopsoas muscle, and when there's a dislocation, there is some typical abnormality and the femoral pulse is not palpable. Okay, so remember that. Demographic variation among examiners. So lumbar lordosis, as I said, do a Thomas test. So you can start off with the Thomas test in the palpation. You don't need to go to special tests for Thomas test. You do the Thomas test in palpation. When you say the lumbar lordosis is exaggerated, the next question is, have you done the Thomas test? Okay. So Thomas test is also called as Thomas well leg raising test. So then you have a question, is there any unwell leg raising? There is no unwell leg raising test. So never make a mistake. Don't say Thomas unwell leg raising test by doing the involved hip. Okay. So there is only a Thomas well leg raising test. Okay. Again, a Delhi based examiner is very fond of asking, what is this? Is there any unwell leg raising test? No, there is no. There is only a Thomas well leg raising test or a Thomas test. Simply Thomas test. So this is the exaggeration of lumbar lordosis. So initial 30 degrees will be compensated by a forward tilting of the pelvis and the lumbar spine. Only after 30 degrees of flexion deformity, it is unmasked. So you do it by flexing the normal side. okay, and you obliterate the lumbar lordosis, and this is the angle of flexion deformity. Do a gentle tap on the diseased limb, and that is the angle of flexion deformity. Now again, some examiners would like to put the hand like this and see for obliteration of lumbar lordosis. Some examiners would say, I would like to put it like this. What do you think? It doesn't really matter. You need to obliterate the lumbar lordosis. The examiner who says palm facing upwards quotes as a point in Hamilton Bailey. It's clinical science. There's a book called Hamilton Bailey Clinical Science, not Short Practice of Surgery. In Hamilton Bailey Physical Science, it is written that you put the palm facing upwards. So this particular examiner in Delhi, again, likes to say that put the palm facing up, but it doesn't really matter. Another examiner would like to put a torch from here and show light. And he'll ask whether you can see the light from there, the other side. So when the light is not visible, he says that the lumbar lordosis is obliterated. Okay, so you need to know who is the examiner who is very fond of light and who is the examiner who is very fond of keeping the palm facing upwards. Okay, with due respect to all examiners. So bilateral FFD, again, some examiners say you cannot do a Thomas test in a bilateral FFD. No, you can still do a bilateral, you can still do a Thomas test, you can flex both the hips and extend alternatively one by one, and when the lumbar lordosis starts appearing, that is the angle of flexion deformity, and you can do on both sides again. Another examiner would like to bring the patient towards the edge of the couch and then test. Okay. So when there is a knee flexion deformity, that is very ideal. You bring the patient to the edge of the couch and you do a bilateral, you do a Thomas test again. You can say it is a modification of the Thomas test. Again, he may argue, you cannot do a Thomas test. Then you can say, okay, I will check for lumbar lordosis, I will check for flexion deformity by flexing both hips and by alternatively extending until the lumbar lordosis reappears. Okay. The other test that you can do for a bilateral FFD, when the examiner says, no, I cannot accept the Thomas test. So you say, prone extension test by Staheley. Okay, so that's the answer. You bring the patient to the edge of the table, you alternatively extend the hip, and look when the pelvis tilts. So that is the angle of flexion deformity. It's called as prone extension test of Staheley. Okay, remember. Yeah. Lynn Staheley, I agree with you. Lynn Staheley is a pediatric orthopedic surgeon, but this can be very well done in adults. Your point is taken. I agree with your point. So palpation, greater trochanter from lateral side, look for level of greater trochanter. See for thickening or broadening in both superior inferior as well as anteroposterior direction. Look for surface, smooth or irregular. Sometimes in Perthes disease there will be an overgrowth of the trochanter in the healing phase and it may appear broadened and even proximally migrated. Okay. So tenderness, trochanteric tenderness, you do a local tenderness as well as you can do a thrust tenderness. Okay. So very important. Posterior, you look for a globular bony mass in the posterior sign, and if it moves on movement of the femur, it means it's the femoral head. Yeah, so you look for a globular bony mass, and if it's moving with the movement of the femur, it means that it's the femoral head. And so what is the Ober's point? There's an Ober's test, there's an Ober's point, and there's an Ober-Young procedure. So maybe the Ober's point, someone? Yeah, so that is a mistake. Ischial tuberosity is not there in the field. Never say that. It is a PSIS and the greater trochanter, medial 2/3 and lateral 1/3. Ischial tuberosity is far below. Where is the hip joint? It's quite above. Okay, so the common mistake you say is that the line joining the ischial tuberosity and greater trochanter. No, ischial tuberosity is not there. It is only the PSIS, greater trochanter, medial 2/3, lateral 1/3. That's it. So that is Ober's point. Ober's test, I'll come to it later. So abduction deformity, as I said earlier, it's a coronal plane deformity. Abduction, so the patient compensates by convexity to the same side, ASI is lower level, apparent lengthening on the same side. Okay, that's it, abduction deformity. Patient has to compensate, so ASI goes down. Adduction, just the opposite. So next is, you have to measure the abduction deformity and the adduction deformity. Okay, if there is an abduction deformity, you have to measure it. If there's an adduction, you have to measure it. So how do you measure for the abduction deformity? So like the Thomas test, in a sagittal plane deformity, in a coronal plane deformity, the test is squaring. Okay, very simple. In a sagittal plane deformity, like a flexion deformity, the method to unmask the flexion deformity is the Thomas test, whereas in a coronal plane deformity, it is the method by squaring the pelvis. Okay. So when in an abduction deformity, in an abduction, abduction deformity, adduction is not possible. That is fundamental rule. Okay. Whenever you say there's a fixed flexion deformity, there is no extension possible. So whenever you say fixed abduction deformity, there is no adduction. Okay, very clear. So whenever there's an abduction deformity, square the pelvis. So the ASI is at the lower level, you square the pelvis by further abduction. Okay, abduction. So it becomes level. So that is the angle of abduction deformity. Okay, then you look at further abduction, how much is possible? Okay, then maybe another 20 degrees. So there is an abduction deformity of 10 degrees and further abduction of 20 degrees is possible. Then you should look whether it is with associated pain and spasm or not. If it is pain-free or painful, that is also very critical. Okay. So adduction is the opposite. Adduction deformity, leg is going to be like this. Okay, so how are you going to do? You're going to further adduct, right? So when you're going to further adduct, so just imagine this 10 degree abduction deformity. Going to further adduct is going to be 30 degrees. So you're keeping the legs across. Okay, it's very difficult for the patient. What you can do? This is a normal hip joint. You can abduct this one. So you take both legs together. That is how you measure a adduction deformity. Okay, clear? So adduction deformity, abduction or abduction is not possible. You further adduct or adduct so that the ASI is at the same level. Then you see the squaring the pelvis, that is the angle of adduction deformity, and do a further adduction to see whether it is associated with pain and spasm. That's it. So common mistake, where do you keep the goniometer? So you have a goniometer, you keep the center of the axis of the goniometer at the hip joint, center of the movement, okay, or axis of rotation. Center, proximal limb is along the body and the distal limb is along the limb. So that is how you keep a goniometer, very important. Should never mistake this, okay. So where do you keep the goniometer? So another method to find out whether, without squaring the pelvis, there is a method described by Kothari. Kothari was a registrar in Bombay University, published in 1953 in Indian Journal of Surgery. So this is a method without squaring. So the examiner may ask you, is there any method to say abduction or adduction deformity without squaring the pelvis? So that is by drawing the Kothari's angle. Okay, so imagine this is the normal side, this is a disease side, so it is a higher level means what deformity? Adduction deformity. Okay, so you draw, so this is the midline, you draw perpendiculars to this line. So this line is the angle of adduction deformity. Okay, in this case, this side, adduction is this side. So this is the angle of adduction deformity. Okay, so this is the Kothari's angle. The point is, what we described earlier was the, what method? This is Kothari's method. Perkins method, perfect. So that was the Perkins method and this is the Kothari's method. Kothari's method, you don't need to square the pelvis, but you need to keep the limbs parallel. Okay, that is very important. This examiner, again from Delhi, he likes to ask this question. What is the other method you done? Okay, that's Perkins. So this is Kothari. You don't need to keep the pelvis squared, but you need to keep the limbs parallel. Okay. And if you say Kothari was a registrar and published in 1953, then he'll be very happy. So abduction, normal abduction is around 45 to 50, adduction is around 30 degrees, internal rotation is 35, external rotation is slightly more, remember that, okay. External rotation is slightly more than the internal rotation, extension up to 15 degrees, hip flexion normal up to 120 degrees. So rotation, how do you look for rotation? This is the normal way of looking rotation, right? Hip and knee extended, okay. So external rotation will be slightly more, internal rotation will be slightly less compared to this. Other method is keep the patient prone. Hip is extended, you rotate the knees internally and external. Okay. So basically you can see rotations in three ways, I'll tell you. So this is the third way. Again you flex the hip as well as the knee and look for rotations. So you have three methods for looking rotation. One is everything extended, the other one is hip extended, knee flexed, and then hip and knee flexed. So what is the advantage in doing in flexion, rotation? Yeah, you can, it is more sensitive. It is more sensitive because the range of motion in flexion is slightly more compared to in extension. So you get a better understanding of the disease process when you do in flexion. So where do you get an exaggerated internal rotation? Any condition where the internal rotation is more than the external rotation. Get a squinting petellate, W sign. Increased femoral anteversion, perfect. So increased femoral anteversion, you get excessive internal rotation, but external rotation is limited. Okay, so that is very particular for increased femoral anteversion. You get in-toeing gait, you get tibial torsion as well. So when you say movements, you look at global restriction, whether the restriction is in all range of motions. Okay, that indicates that there's an arthritis. Okay, there's a restriction of all range of movements, means it could be an inflammatory arthritis. When you have a degenerative arthritis, secondary to Perthes or any other condition, initial movement is only in one single plane. Okay, for example, you have a Perthes disease that goes into degenerative arthritis. Initially, it will be only in flexion extension plane, abduction, adduction, rotations will be preserved. So, but in inflammatory arthritis, you get global restriction, okay, unless the patient is in remission. Next point is, what is sectoral sign? What is the sectoral sign? Yes, it's a differential rotation. In flexion, there will be less internal rotation. Okay, that is seen in classically avascular necrosis of the hip or idiopathic osteonecrosis. You get less internal rotation in when the hip is in flexion. So what is axis deviation then? When you say sectoral sign, you should know what is axis deviation. What is axis deviation? Anyone? First. No time. Dr. Kulkarni is looking at me. Sorry, he's sleeping. Yeah, so in axis, what happens in slip upper femoral epiphysis? The leg is extended, adducted, and externally rotated. Okay, so the axis is going to be like this. Instead of like this, the axis is going to be from the opposite leg to this shoulder. Okay, so this is the axis deviation. So when I do this, normally when I flex the hip, you can bring it to the chest, but in axis deviation, where does it go? It goes to the ipsilateral shoulder. Okay, so it is also called as, it's called as knee axilla sign. Knee axilla sign. You're bringing the knee towards the axilla. So that is knee axilla sign. And always you look at free range of motion. As I said, in degenerative arthritis, secondary to Perthes or any other condition, the flexion extension may be normal, only the abduction, adduction may be free. So if there is a free range of motion, you should mention. Okay. So as I said earlier, whether there's any pain and spasm or not, whether range of motion is associated with pain and spasm, very, very important. Further flexion deformity of 40 degree, further flexion is associated with pain or spasm, means it is arthritis, okay. If it is free, then you know it may not be arthritis. Terminal restriction of pain, where do you get terminal restriction? Synovitis, excellent. Pain only during a particular movement, pain only during external rotation. It can be an extra-articular cause, okay, it can be an extra-articular cause. Exaggerated range of motion. For example, you get exaggerated extension. Slip capital femoral epiphysis, you get exaggerated extension. You should be very careful of if you're going to say there is a flexion deformity in a slip. Okay, if you're saying a flexion deformity in a slip capital femoral epiphysis, that is going to be dangerous. So in a slip capital femoral epiphysis, you're going to get exaggerated extension up to 30 degrees of extension. And also you can get exaggerated range of motion in all directions. You can get in Tom Smith arthritis of infancy, you can get in DDH, and even in post-polio residual paralysis. Okay, so all these are very important for exam. Measurements, always apparent lengthening from sternum to the medial malleolus, true lengthening from the ASIS to the medial malleolus, that's it. So, as I said earlier, adduction deformity, further adduct, so that the ASIS comes down, okay, and that is the measure of the adduction deformity, and look for further adduction. So when you measure, now there is a difference between measuring abduction deformity and measuring the true length, okay. So when you measure, suppose you have a abduction deformity, the ASI is lower level, you squared the pelvis, so this is 20 degrees. So now this is at 20 degrees, and the ASI is at same level. So can you measure it? So what do? You recreate the deformity, okay, you reproduce the deformity in the normal limb. So that is how you should measure, okay. So when it's an adduction deformity, is tough, okay. The ASI is higher level, you bring it down, so the leg is already like this. So bringing this to opposite side, so it's a tough job, but you should do it, okay. You have to bring the leg across, and that is how you measure. So this only happens in measurements, okay, measurements. Remember, not while measuring the abduction or adduction deformity. When you're going to measure true length, okay, that is the time when you do a recreation or a restoration of the deformity in the normal side. Then segmental measurements, Bryan's triangle, Nelton's line, Shoemaker's line, very important. I'll show you so there is no palpatory